Hello everyone, this is Dr. Garima Sachdeva and today we'll be discussing about various pre-malignant vulval lesions. The topics that I'll be covering today will include the various causes of vulval itch, which are lichen sclerosis, lichen planus, vulval psoriasis, lichen simplex, vulvodynia and VIN. So stay tuned, you will definitely find it useful.
Okay.
So have you read this topic, Pre-malignant vulval lesions?
Yeah, just went through.
Okay. Okay, so in case of vulval disorders, the basic evaluation include history and examination. History over the most common history which the patient will present with is itching or pruritus. To see for the duration, location, quality of life, medicines she is on, any medical history of diabetes, anemia, sexual history, menopause, whether she's premenopausal, postmenopausal. Examination will include general physical examination, skin features, knee examination of knee, waist, because there are certain lesions which are present or which involve these areas as well. Uh, you have to do a per abdomen, per speculum, per vaginal, and local examination. So vulval itching, it can be because of various irritants, and in all these vulval disorders, you ask them to avoid these irritants. So what are these irritants? These could be hygiene products like soaps, bubbles, shampoos. These could be medicines like oral contraceptive pills, spermicidal agents, or steroids. Or their patient might have allergy to certain things like latex allergy, allergy to condoms, food allergies, allergy to shampoo, perfumes, panty liners, etc. So
Okay.
all these are asked to avoid. Now, if a patient comes with vulval itch, how will you evaluate? First, you will see whether there is any vaginal discharge or not. If there is vaginal discharge, then you have to take a swab, because then you have to rule out other sexually transmitted or chlamydia, gonorrhea, all those, candida, everything you have to rule and you have to treat.
Okay.
In case there is no discharge, then you see whether there are features suggestive of any cancer or VIN. In case that is there, you have to take a direct biopsy. In case there are no suggestive features, then you see how whether the architecture of the vulva is maintained or not. If the architecture is maintained, then your two differential will be eczema or psoriasis. The architecture is not maintained, then it could be lichen sclerosis or lichen planus.
Architecture of vulva.
Yeah,
If it's not maintained, means how will it be?
it will be distorted, like abnormal looking,
Okay.
thinning of the vulva.
Okay.
Okay. Then in both the cases, you have to ask for vulval care, which will be avoiding the irritants. And you can give, for eczema psoriasis, you can give moderate potency topical steroids, and for lichen sclerosis and lichen planus, you have to give super potent topical steroids like clobetasol. And then refer for diagnosis, ongoing investigations, and treatment if you're not confident. Or if you're suspecting cancer, then you have to refer to vulval clinic or cancer clinic. Okay, understood.
Yes, ma'am.
Okay, so this is a case. Um, you have to tell the diagnosis. Since you have read, so probably you can try.
6-year-old postmenopausal lady has been referred for so yes, night. First one looks like lichen sclerosis.
Yeah, it is lichen sclerosis only. Okay, so this is, so here you can see the architecture is lost.
Okay.
That's
Let's
what's
discuss.
meant by. Okay, so it's generally seen in postmenopausal females. Patient presents with itch, soreness. Uh, you have to treat them with steroids. Lubricants are usually not beneficial. Uh, there is thinning of skin, and biopsy there is typical parchment paper or cigarette paper like appearance, and subepidermal hyalinization and deeper you can see WBCs or inflammatory infiltrate down below.
Okay.
So symptoms of lichen sclerosis, itching, soreness, patient can present with urinary symptoms, dyspareunia. It is associated with other disorders like autoimmune disorders like Crohn's disease, type 2 diabetes, Graves disease, anemia, and signs include pale areas. There can be fissures, figure of 8 appearance where it is also involving the perianal area.
Mm. Okay.
Cigarette paper or parchment paper appearance, adhesions, and steroids because they cause immunosuppression. They can aggravate these symptoms. So steroids can aggravate the symptoms of these pathologies. They are also used for treatment.
But we are treating them with steroids only.
Typical steroids we give, no. These oral steroids, if patient is on prolonged steroids, these are immunosuppressants. So
Okay.
they also aggravate their symptoms.
But steroid is only the treatment also, topical steroid. And how long do we give?
I will let you know. It is 3 months. I'll let you know how to give.
And
Then,
uh, and another thing,
yeah,
I wanted to ask something. Ma'am, please move to the previous slide. I wanted to ask something, but I forgot. Okay, when I remember, I'll ask.
okay. So
And
that
what is the cause of it?
it is primarily autoimmune, and it is also associated with other disorders like Crohn's disease, type 2 diabetes, Graves disease, anemia, immunosuppression, all that. Then, how do you diagnose? First is the clinical diagnosis. In case you do a biopsy, you will see hyalinization and thin epidermis. You can do a patch test to rule out any kind of allergy. Then thyroid testing, you can do swabs in order to rule out infection. Complications include squamous cell carcinoma, which is seen in 5 in 100 patients. 5% of the patients with lichen sclerosis can have squamous cell carcinoma. So you have to ask them to be in a persistent follow-up. It can result in clitoral pseudocyst or sexual dysfunction.
Clitoral pseudocyst. Okay, and what is patch test? What do we do?
So, like for allergy, you put a at a particular area, you expose that agent and you see if there is any kind of allergy. If it is, you're suspecting it to be because of allergic
Okay.
thing. Okay.
Okay.
Management, you have to involve the MDT team. General advice will be you ask them to quit smoking and avoid irritants. Then the first line treatment here will be clobetasone, which is high potent steroids. It comes as a 30-gram tube, and you ask them to use like a little bit only on like it should cover up till the distal phalanx only. Okay, and then they have to apply daily for 1 month, then alternate day for the next month, and then weekly for the next month, like that.
30
So they have to
grams
gradually taper it.
daily, daily for 1 month, then subsequent month alternate days. Then
Yes.
weekly. Okay. Altogether 3 months. Okay.
Then, if the patient is not responding, then you can give them tacrolimus or retinoid UV therapy. Then, in case the patient has not responded after 3 months, then you have to refer them also to the vulval clinic for biopsy. Then, how do you, if the patient has responded, how do you follow up these patients? Uh, 3 months initially. At first you will call them at 3 months to assess the response, and then if the patient has responded, then annually. You also ask the patient to do the self vulval exam.
Self vulval exam.
They have to check for any new lesions or any other problem. So self-examination of vulva. This 3 months you're calling and first you'll call at 3 months and then every yearly. In
Okay.
between also they have to do a self-vulval exam in case they have any problem they have to come back. Okay.
Okay.
Then next case.
If no response after 3 months, where are we referring?
Then vulval clinic and you have to ask them for biopsy. If the biopsy findings are suggestive of lichen sclerosis only, then you give them tacrolimus or retinoid UV therapy.
Okay.
Then this case.
This is open vulval plain topical. This thing vulval planus.
Yeah, this is lichen planus.
Lichen planus.
Yeah. So here the you have to see all these PP things will come polygonal, purple, then
Okay.
plain topped, right?
Okay.
So all these you have to remember the symptoms of lichen planus as 9 P's. So
Okay.
these are it's a papillosquamous disorder. It is pruritic. The lesions are polyangular, plain topped, pigmented, purple colored, present as papules or plaques. On the nails, it affects the nails. There is a pterygium. Okay.
Okay.
And also it causes penile annular lesions.
In
Generally,
when
it can cause, it is associated with, it involves mucosa. Lichen sclerosis was not involving mucosa, it involves oral mucosa, penile mucosa.
the spinal annular lesions in males.
Males, yeah.
Okay, and this is also autoimmune only.
Yeah, this is also autoimmune. Antibodies are seen in 61% patients. Sometimes it is also associated with infections like hepatitis B or C. It's an uncommon chronic pruritic disease characterized by voluptuous, flat-topped papules that are usually seen on wrists and legs.
Okay.
Then there are three clinical presentation. One is a classical, like we have discussed. So in which there are typical papules which will be found on the keratinized anogenital skin with or without stria on the inner aspect of the vulva. Then it could be hypertrophic, where there is thickened warty plaques which may become ulcerated, infected, or painful. Then erosive, which is the most common subtype to cause vulval symptoms. So erosive is the one which is most common and it is associated with morph mucosal surfaces are eroded as the edges of the erosion. At the edges of the erosion, the epithelium is morphed and a pale network is seen, which is called as Wickham stria. So you can see it here. So these stria, white pale stria, you can see.
Okay.
So that is Kim's trial. So this is seen in erosive type. Management general advice will be you ask the patient to avoid irritants, you treat the cause, give them steroids. So the same clobetasol ointment is given because it is associated with infection. You can combine it with antibiotics and antifungal. 75% patients improve with it. You can also give vaginal steroids. If the patient is not responding, first you will refer to the vulval clinic to for the biopsy because there is risk of cancer. Uh, then, if it comes out to be the same thing, then you give them oral cyclosporin. Other things that you can give biological agents like basilicimab. Okay.
Basilix. Okay.
Then again, follow up is the same. You call them after 2 to 3 months, followed by annually.
This is given in the form of this basiliximab
Oral.
oral dose. So, lichen planus only there is risk of cancer.
Lichen sclerosus also. Lichen sclerosus carries a higher risk. With,
Okay. 5% squamous cell carcinoma.
yes. Okay.
Okay.
The next case.
32-year-old presented with vulval itching and soreness, aggravated during her periods, relieved during summer. I don't know what it is.
Hmm?
I don't know.
Plaque lesions with scale, symmetrical lesions if this comes. Lesions, plaque-like lesions which are
This is
symmetrical with or without scales involving.
psoriasis.
Yes, this is psoriasis. Wherever this word comes, no symmetrical lesions, pinkish lesions.
Okay.
Okay, so that the answer will be psoriasis then. So psoriasis, it can affect the other areas like under surface of the breast. It can cause red patches on the skin, scaling spots on the skin, cracked skin, itching, soreness, affects cause pitting of the nails, swollen and stiff joints. So symptoms include vulval psoriasis is again a chronic inflammatory disorder seen in 2% of the general population. Symptoms include vulval itch, soreness, burning sensation. Lesions are well demarcated, brightly erythematous. So these buzzwords you have to remember for everything. For
Mm-hmm.
lichen sclerosus, you have to remember no mucosal involvement like oral involvement or penile mucosa, nothing. Only skin, vulval involvement will be there.
In which
And the
one?
skin will be thin,
Lichen
pale.
sclerosis.
Yeah. Lichen planus, all peas thing. It will
Okay.
involve one, it will involve the mucosa, then all peas. Purple, mollaceous, plain topped,
Okay.
polygonal, all that.
In lichen sclerosis, what is not involved?
Mucosal involvement is not there, which is there in lichen planus.
Okay.
Okay,
Okay.
then signs of vulval psoriasis: well demarcated, brightly erythematous plaques, often symmetrical, frequently affects natal cleft, usually lacks scaling due to maceration. Sometimes fissuring can be there. It can also involve scalp and umbilicus.
Okay.
Complications: it may be worsened by Koebner's phenomena or by irritation from urine, tight fitting clothes, or sexual intercourse. What is Koebner phenomena is at the site of the trauma, if like these lesions can precipitated by trauma. So in a area of the skin which previously didn't have lesion, but due to any trauma, lesions can appear. So it is the appearance of new lesions on the previously unaffected skin.
Okay. Can treat a trauma, any trauma, any trauma.
Yeah, suppose the patient gets hit by something
Okay.
or by she's walking, her a leg touches the bed or the table, she can get lesions there like that.
That will disappear immediately, no?
No, it will not disappear, it will be there.
No, like if we get any rashes,
No, these are lesions, these are psoriatic lesions which appear due to trauma. It is not rashes. That's Koidner's phenomenon. These scaly lesions appear like this hair at the site of trauma. Okay, how do you diagnose? It's a clinical diagnosis. You can examine the skin, nails. If the diagnosis is in doubt, then you do a punch biopsy. How do you treat? Treatment is avoiding the irritating factors, using emollients soap. You give topical steroids. For lichen planus and lichen sclerosus, you were using high potency steroid. Here you are using low potency or weak or moderate steroid.
okay.
Okay. If the patient doesn't respond, then you go for clobetasol, that is high potency steroid.
Okay.
Then combined preparation containing antifungal or antibiotic may be required in case there is infection. It comes with a name trimovate. Weak coal tar preparations, vitamin D analogs like talcacetol can also be given. So here vitamin D is also given. Psoriasis. Okay. So for psoriasis, vitamin D is an option.
Okay.
Then this question,
Patient suffering from lichen sclerosis complains of no relief after topical steroids. What is the next step in management? Lichen sclerosis. We have to do biopsy.
yeah, you have to do the biopsy. Then
Patient suffering from psoriatic lesions on vulva and scalp not responding to topical steroid. Here we give. Do we do biopsy here?
no, here you give calcipotriene cream, which is vitamin D basically.
That calcium is
I
vitamin D.
think for psoriasis you give vitamin D, coal tar, etc. So
Right.
it's a form of vitamin D. It is used to treat psoriasis.
Okay.
It works by slowing down the growth of the skin cells. Then next,
Agent not and vitamin D3, like can we give a cholecalciferol, which is normally available?
that is oral, no? Here you're giving
Okay,
topical.
this is topical cream. Okay, okay, okay. Patient not responding to steroids. Patient. What is that calcipotriene?
The same, I think spelling is wrong. This only.
This only calcipotriene. Okay, so that only.
Hmm?
That only.
I didn't get.
Oh, I don't know. What do we give?
Paget's is basically a cancer only. So you have to do the surgical excision. Excision. Usually they won't respond to steroid.
Okay. If there is no response, we have to do surgical excision.
Yeah, Paget's anyways you have to do surgical excision because the prognosis is very poor and it spreads really fast. If they ask you anyways about the treatment of Paget's also, it will be wide local excision. You treat
Okay, but initially we give steroids.
no, you don't give steroids still.
We don't give steroids at
If you
all.
have a doubt, you can try, but these patients will not respond, and the main management is surgical excision only.
Okay, right, local excision.
Then this question.
40-year-old Teresa is presented with vulval pruritus on and off from last 5 years. She is on antidepressants for major depression. She also has been treated in the past for recurrent tinea infections. On examination, is bilateral like inflammation, erosions, and scarring. They are asking for the diagnosis.
Yeah.
Lichen sclerosis.
No, this is not lichen sclerosis.
I don't know.
It is lichen simplex.
Simplex. Oh, there is
Lichen simplex
simplex.
chronicus. So it if they give you a scenario which has any underlying disease, like in this
Mm-hmm.
case there is chronic
Tinea.
depression, infections.
Okay.
It is
Mm-hmm.
mostly this only, lichen simplex. So in this there will be underlying dermatosis, like could be atopic dermatitis, any underlying condition will be there, any fungal infection, allergic contact dermatitis, skin conditions causing pruritus due to renal failure, obstructive biliary disease, Hodgkin's lymphoma, thyroid disease, polycythemia, environmental factors like heat, sweat, rubbing,
Okay.
irritants such as harsh skincare products, psychiatric disorders like anxiety, depression, OCD, dissociative experience. These are all associated with it. Emotional tensions are in predisposed people
Okay.
can also induce itch and thus begin the chronic itch scratch cycle. So all these underlying conditions will be there. Okay.
Okay.
Symptoms will be the same, itching and soreness. Signs will be lichenification. So here they would specify lichenification. And what is lichenification? It is thickened, slightly scaly, pale or earthy colored skin with accentuated markings. Then erosions or fissuring, excoriations as a result of scratching.
Mm.
Pubic hair is often lost in the area of scratching.
Okay.
Diagnosis, it's again a clinical diagnosis. In the history, you have to ask about any mental disease. You have to do the examination. Further investigation, you have to rule out any kind of infection. Skin disorder for patch test in order to rule out any allergy. Ferritin testing, biopsy.
Okay. And reason for losing pubic hair?
Because of any area where you scratch so much and there is thickening, hair will anyways be lost.
Okay.
Okay. Then how do you treat? You avoid the precipitating factors. You ask the patient to avoid heat, use emollient soap, topical corticosteroids. Here also you use high potent topical steroids like betamethasone, clobetasol for limited periods. You can combine it with antifungal or antibiotic if there is secondary infection. In case it is allergic in cause, then you can give them antihistaminics. And in case there are mental health issues, then you also give them CBT,
Okay.
behavioral therapy. Okay.
Okay.
Then coming over to vestibulodynia. What is vestibulodynia and what is vulvodynia? So what is vestibule? It is at the opening of the vagina. That area is called as vestibule. And
Okay.
vulva is the entire thing. So
Okay.
vestibulodynia in both the patients present with chronic pain in vulva, whether provoked or unprovoked. Vestibulodynia pain is localized to the opening of the vagina and it is usually provoked by touch or vaginal penetration.
Okay.
Uh, in this vulvodynia, in this it can be vulvodynia can be provoked or even unprovoked, and it is described as burning, sore, or irritation around the vulva. Continuous pain around the vulva associated with burning, soreness, and irritation.
Here, pain is not affected by lidocaine. Then,
Hmm?
no, no, here pain improves with topical lidocaine. Whereas here it is not.
Because it is vestibulodynia is usually provoked.
Okay.
Vulvodynia can be if it is it could be provoked or unprovoked. If it is unprovoked, then it will not be affected by lidocaine.
Then, okay, treatment.
Okay. And if you examine the patient in both the cases, you will see normal appearance of vestibule and vulva.
Okay.
Vestibulodynia, since it is provoked, so if you do a cotton, put a you stimulate with a cotton swab, the patient will have pain. Okay,
Okay.
generally the patient anyways pain, so
Yes.
it will not be provoked. Okay, by cotton swab, and since it is provoked, then the lidocaine, if you apply local
It
lignocaine,
will work.
vestibulodynia might improve. Vulvodynia, generalized vulvodynia usually doesn't.
Here, pain is not provoked by examination, though patients may report that areas palpated areas. No, I don't get it. Like, here they feel the pain when it is provoked. Here, pain is not provoked.
Hmm.
Then, when do they feel the pain?
Continuous pain is there.
Oh, there will be continuous pain. Okay.
This thing.
Okay.
Okay. Then this question.
As the register, you are seeing a 21 partner in the clinic. They have known each other for 6 months but haven't achieved vaginal penetration despite repeated attempts. The woman has never penetrated before this and describes her vagina as a brick wall. There is no significant past medical history and she is not taking medication. On examination, she appears to be healthy. Vaginal expansion reveals involuntary spasm of the use of oxygen and other perineal muscles. True. This is primary vaginismus.
Yes, this is primary vaginismus. Since there is involuntary spasm of the pubococcygeus muscle, so there is vaginismus, and since she has never had sex,
Mm.
it is primary.
Okay.
Okay. Next question.
A 21-year-old woman tells you as the one area in her labia continuously feels as it's burning. She finds that massaging the area helps, especially when she uses olive oil. There is no sickness or medical and she is not taking any medication. Vagina and vulva appear normal when you touch the labia. This thing is vulvodynia.
Yeah, it is vulvodynia. Because there is continuous, and when you touch again, she's having. So continuous pain is there. Okay.
Okay. But in generalized,
Here.
yeah, this is vulvodynia, correct.
Yeah. So vulvodynia, there is long-standing unexplained pain, may be associated with urinary symptoms like interstitial cystitis. Examination, everything is normal. Complications, it can be associated with sexual dysfunction or psychological morbidity. Diagnosis is the diagnosis of exclusion. How do you treat them? You give them emollients. Drug of choice is tricyclic antidepressants like amitriptyline. If the patient is unresponsive, you give them gabapentin or pregabalin. Alternative treatment include topical lidocaine or this CBT acupuncture. In resistant cases, you have to refer them to the pain clinic.
Okay.
Then vestibulodynia, it is provoked. Pain is on the insertion of tampon or sexual intercourse. It may be associated with any kind of infection like candidiasis.
Okay.
Again, in this case, examination will be normal. However, since it's provoked, if you apply a cotton tip, the patient can have pain, focal tenderness. Okay. Complications same, sexual dysfunction and psychological morbidity. It is again a diagnosis of exclusion. Treatment is almost the same. You give them emollients, avoid precipitating factors, topical lidocaine, pelvic muscle feedback, vaginal drainers, vaginal tens, CBT, acupuncture, TCA, amitriptyline, or if it is not responding, then you have to do modified vulvectomy.
Vestibulectomy. What is modified vestibulectomy?
Move the vestibule where the pain is there. Okay, that's the last resort.
And cause?
Huh?
Cause? What is
Sorry?
the cause? What is the cause?
It is psychological only.
Psychological, both vestibulodynia as well as
Yes.
vulvodynia.
Yes. Vaginismus is also primary psychological. Secondary could be because of scarring or something.
Okay.
Then VIN, vulval intraepithelial neoplasia. So there are two types of VIN, usual or unusual. Usual is caused by HPV infection. These are usually warty and basaloid lesions. Unusual or differentiated, it is associated with lichen sclerosis, not associated with HIV, and here there are keratinizing lesions. Okay.
Okay.
Then symptoms include there could be lumps, erosions, burning, and itch or irritation. Signs are variable. They can be raised, white, erythematous, or pigmented lesions, which can occur, and these may be warty, moist, or eroded. These can be multifocal or unifocal depending on what is the cause. The risk of squamous cell carcinoma here is quite high. It is between 9 to 18%. Then diagnosis, here you have to do a biopsy where you will see loss of organization of squamous epithelium with variable degree of cytological atypia. Multiple biopsy may be required as there is risk of missing, because sometimes it is multifocal, right? So
Okay.
you might need to take multiple areas, biopsy from multiple areas. Then since it can be associated with CI because HPV, right? So
Mm.
be associated with CIN, so you have to do colposcopy.
Okay.
And in case perianal lesions are there, then you also have to do anoscopy.
Okay.
Then this is how you differentiate. So this
Mm.
is usual type where their warty lesions are there. So
Okay.
this is HPV associated.
Mhm.
This is the unusual or differentiated type where the which occurs in the background of lichen sclerosus or lichen planus, and it is not related to HIV, to
Mm.
HPV.
Okay.
Okay, so other risk factors for usual VIN include smoking, sexual promiscuity, chronic immunosuppression.
Mm.
Okay, these are warty or basaloid, as you can see.
Okay.
Uh, Unusual are keratinized. These
Okay.
usual are seen in young because HPV is seen in younger population. So these are
Okay.
seen in younger patients, 30 to 50.
Okay.
Unusual is seen in postmenopausal older patients, 60 to 80.
Okay.
And these are usually multifocal disease,
Okay.
and these are unifocal, and they can be associated with vaginal involvement, CIN, intraepithelial neoplasia of anal canal. All that can be associated with this
Okay.
HPV.
Here, unifocal means confined to one
One
side.
area, yeah,
Here, it may be bilateral.
yeah, because it can. Multifocal means other areas like cervix can be involved, vagina
Okay.
can be involved, anal canal can be involved, all that.
Okay.
Because HPV can be anywhere, right?
Okay.
So how do you manage these patients? Since it's precancerous and high risk of cancer, then you have to do excise. You have to do a wide local excision. Other alternative treatments include imiquimod cream 5% or vulvectomy.
Okay.
Alternative treatments are local destruction, 5-fluorouracil, or you just supervise and follow if the patient doesn't want, but that is not usually done. So the best treatment if they ask you is local excision.
Sure.
Clear?
Okay.
So this was all about the vulval lesions. Any doubt?